Hello everyone, today we are going to learn acute cellulitis, etiology and pathology. Acute cellulitis is an acute, diffuse and purulent infection which is subcutaneous subphagia in the muscle gap or in the deep cellular tissue. The main pathogen is hemolytic streptococcus, followed by Streptococcus aureus and Escherichia coli or other streptococci. Because hemolytic streptococcus infection can release hemolysin, streptokinase, hyaluronidase, or so on. Its inflammation is not easy to be limited. With an unclear boundary with normal tissue, spreads quickly, can cause extensive subcutaneous tissue inflammation, exudation, edema in a short period of time, and it can lead to systemic inflammatory response syndrome and endotoxemia, but it is often negative in blood culture. If it is caused by Staphylococcus aureus, the lesion is relatively limited due to the action of coagulase produced by bacteria. The acute cellulitis usually presents superficial and deep clinical manifestations. For superficial acute cellulitis, the affected part is red, swollen, hot, and painful at the early stage, and then inflammation rapidly spreads along the subcutaneous tissue to the periphery. Swelling becomes more apparent and different sizes of blisters could appear. The pain is more intense. The local skin is red and the redness can fade slightly after pressing by fingers, and the boundary of red swallowing edge is unclear. Lymph nodes adjacent to the lesion are often swollen and painful. When the lesion aggressively, the skin blisters break out and exudate flows out, and part of the skin becomes brown. For deep acute cellulitis, the epidermal symptoms is not apparent, but it affects the diagnosis and treatment because of the deep lesions, and there are often shiver, high fever, headache, weakness, and other symptoms. Severe poisoning symptoms such as extremely high or too low body temperature, and even conscious changes in a severe case due to the difference between types and toxicity of pathogens, contagion of pathogens and infected sites. There are several spatial types as follows. For superficial cellulitis, lesions or infection appears first. Redness, swallowing, and pain are apparent. It spreads quickly to the peripheral. There is an unclear boundary between the lesion part and normal tissue. The central part is often necrotic. For deep cellulitis, there are local edema, deep tenderness, and severe systematic symptoms. Subcutaneous gangrene of newborn. It is more common in back and hip. The newborn is febrile, does not eat milk or dopes off. The affected skin is red and hard and expands. The center is softened with blisters, and the skin is necrotic and breaks. In a serious case, gas-producing subcutaneous cellulitis, the pathogen is anaerobic. Inflammation only appears in the subcutaneous connective tissue. It is the same with common subcutaneous cellulitis at the early stage, but it develops fast and produces crepitus, more common in lower abdomen and perineum. Mouth, floor, and submaxillary cellulitis. The cellulitis originates from mouth or face. it is easy to block for ventilation, and the submaxillary region and mouth floor are swollen in case of mouth. The face case shows redness, swelling, fever, and pain and systematic reactions more common in children. Diagnosis and differential diagnosis. It is not difficult most to diagnose according to the history, science, and the increase of white blood cell count. The pathogen can be detected from smears of serous or purulent secretion, and the blood and purulent bacteria culture and drug sensitivity tests are helpful for diagnosis and treatment. Disease is to be differentiated. When there is hard skin at the early stage for subcutaneous gangrene of newborn, it should be distinguished from the scleroderma. For the later, the skin is not red and the body temperature does not rise. When the submaxillary cellulitis of children causes tachypnea and agglution, it should be distinguished with the acute angina. For the later, the submaxillary swelling is mild, while the redness and swelling in the oropharynx are apparent. Difference between the gas-producing subcutaneous cellulitis and the gaseous gangrene. For the later, the trauma often involves muscles prior to the onset. The main lesion is mainly the necrotic myostasis caused by Clostridium perfringens. The wound often has some kind of smell. The X-ray plain film shows gas shadow among muscles. The morphology of the pathogen can be roughly distinguished by smears of pus, and bacteria culture can help to identify the pathogen. Prevention and treatment. Pay attention to skin hygiene and prevent skin injury. Infects and aged people are less resistant and should be paid with more attention for life care. Antibacterial agents, nephilin or cephalosporin antibiotics are generally used first, and metronidazole is added in case of suspected anaerobic infection. Drugs should be adjusted according to clinical treatment effect or bacteria culture and drug sensitivity. Local treatment. For the acute cellulitis at the early stage, 50% magnesium sulfate for wet compress, jinquang powder, istamol ointment, and so on can be applied, and it should be incised for drainage in time in case of abscess. For the mouth, floor, and submaxillary cellulitis, it should be incised as early as possible for pressure relief. To prevent the laryngeal edema and tracheal compression. For other types of subcutaneous cellulitis, severe small incision may be made at the lesion for pressure relief to alleviate that expansion of subcutaneous inflammation and reduce skin necrosis. For gas-producing subcutaneous cellulitis, the patient must be isolated, and the wound can be treated by washing with 3% hydrogen peroxide solution and wet compression. Symptomatic treatment. Attention should be paid to improve the patient's whole body state and maintain the stability of the internal environment. In case of high fever, cold compress can be selected for physical cooling. Nutrition and body fluid balance should be maintained in patients with eating problems. In case of tachypnea, oxygen inhalation or auxiliary ventilation should be given. Erysipelas, etiology and pathology. Erysipelas is an acute non-purulent inflammation caused by infection of cutaneous lymphatic network by beta hemolytic streptococcus. It is commonly seen in lower limbs and face. In most cases, there are some lesions of the distal skin or mucosa, such as toe skin injury, tinea pedis, oral ulcers, sinusitis, etc. After the onset, inflammation occurs in the skins of lymphatic networks distributions area. The lesion spreads fast and often involves drainage lymph nodes. There is rare tissue necrosis or pus in the local area, but the systematic inflammation is apparent, and it is easy to cure but often reoccurs. Clinical manifestations. It is commonly seen in lower limbs and face. The local part presents flaky reddish and bright red. The middle is light in color. Skin in the red and swallow area may have tension blisters. There is a burning pain in the local part, and the lymph nodes are swollen and painful in the drainage area. However, the skin lymph nodes are rarely purulent and broken. It may be accompanied by headache, fear of cold, fever, and other systemic symptoms. System sepsis may occur in case of aggravation. In addition, after erysipelas is treated and the condition turns better, lymphatic obstruction and stagnancy of lymph fluid may be caused by recurrence of the lesion, finally forming lymphedema, lymph swelling, and local skin thickening, and developing into elephantiasis. This is a comparison between acute cellulitis and erysipelas. Prevention and treatment. Keep the skin clean and treat small wounds in time. Wash and sterilize hands to prevent cross-infection. Before and after contact with patients with erysipelas and dressing change. Erysipelas related tinea pedis, ulcers, and sinusitis should be actively treated to avoid recurrence. Treatment. Rest, raise of affected limb. Hot compress with 50% magnesium sulfate. Intravenous antibiotics such as penicillin and cephalosporin antibiotics. Simultaneously treatment of erysipelas of lower limb and tinea pedis. That's all for today. Thanks.